Manju, നമ്മുടെ വാട്സ്ആപ്പ് ഗ്രൂപ്പില് we are live on YouTube ഒന്ന് പോസ്റ്റ് ചെയ്താൽ.
ഓക്കെ ചാറ്റ് ബോക്സ്
നമ്മുടെ PG ഗ്രൂപ്പിലും
സർ ഇത് വാട്സ്ആപ്പ് ഗ്രൂപ്പ്. ഓക്കെ
വാട്സ്ആപ്പിലെ PG ഗ്രൂപ്പിലും നമ്മുടെ PG ഗ്രൂപ്പ്
IPS കേരള സ്റ്റേറ്റ് 1-2 ബ്രാഞ്ച് അതെല്ലാം. ഓക്കെ. സർ നമ്മളുടെ മറ്റേ ലൈസൺ ഗ്രൂപ്പ് അതിലൊന്നും ചെയ്തിട്ടില്ല അല്ലേ?
അല്ല, അതിലും ഇട്ടോട്ടോ മഞ്ജു.
ഓക്കെ.
നേരത്തെ ഇട്ടിരുന്നു, എന്നിട്ടില്ല.
എന്താ കണക്ടിവിറ്റി ഭയങ്കര പോറായിട്ട്.
I think we are live on YouTube. Sudeep. Okay, if the president gives permission, I think we can proceed. Madam, Madam co-host ആക്കിയിട്ടുണ്ടോ സുദീപ്? ശ്രീല Madam co-host ആക്കിയിട്ടുണ്ടോ? Hello, Sudeep. Okay.
ആക്കിയിട്ടുണ്ട് സർ.
Okay, fine. Rajesh, my voice is also audible, isn't it, Rajesh?
Yes, sir.
Okay, Sudeep, are we ready to go? Sudeep?
Hello.
Ready? Shall we, Sudeep? Dr. Sudeep?
Yes.
Caller is ready. Caller.
ഒരു മിനിറ്റ്. ഇതില് സൗണ്ട് കേൾക്കാമോ സാർ?
കേൾക്കാം. Okay, ready? Okay, a very warm good evening to each and everyone who have logged in. Respected President, IPS Kerala State Branch, Dr. Sudeep, the most respected Secretary of our branch, Dr. Manju, our speaker for today, the very revered Dr. Srila ma'am. Thank you for joining us. all the other dignitaries of executive committee members of the IPS Kerala State Branch, all the members who have logged in through our Zoom platform, and those who have joined in through our YouTube channel. A very warm good evening to each and every one of you. Today we are again proceeding with our IPS Kerala webinar series, which we used to do every month, and I'm sure Manju will have a lot to speak about our oncoming scientific programs in the coming months. So welcome to each one of you to the IPS Kerala talk series. Yeah. I request all of you to mute except the dignitaries and the speaker, to request you all of you to mute your mic. Today, like I said, we have a very, very important person as a speaker, and who will be introduced by our moderator a little bit later, Dr. Srila, and a very, very important and pertinent topic. Probably something which is a little bit alien to us, the radiographic aspects. So, like you all, I am also very much excited on this 18th of August, as we have logged in to this web talk series. Today, the 18th of August, Dr. Sudeep, as you noticed, and Dr. Prashant and Rajesh, they all came in a little bit late. The reason is that today, 18th of August, is National Men Grooming Day. So I think all men have gone and groomed themselves. You look at Sudeep, you can see what I meant. So a very hearty National Men Grooming Day today, 18th of August. And to all the postgraduates here, today, 18th of August, is also National Never Give Up Day. I don't know, many of you knew it, but today is National Never Give Up Day. So this is a motivational day for you, probably the 18th of August, and to reiterate that never give up, go forward full steam, and aim for that the big goal that you have in mind. So Never Give Up Day. And to Srila ma'am, and to all those research-oriented, ma'am is the head of Department of Oral Medicine and Radiology. Today, 18th of August, also you should know that is a World Research for the World Breast Cancer Research Day. Today, 18th of August, is a very important day. Those who are into for this very വളരെ മാരകമായിട്ടുള്ള ഒരു അസുഖം നമ്മുടെ ഇടയിൽ റാമ്പന്റ് ആയിട്ടുള്ള world the breast cancer. So today is World Breast Cancer Research Day. So 18th of August is an ideal day for due to all these various reasons. So let me once again welcome you all, and may I now request our secretary, Dr. Manju, to add on the presidential caller on Dr. Sudeep.
Thank you, sir. So welcome you all to the program. Respected President Sudeep sir, President-elect Rupesh sir, then all the executive committee members, then our distinguished speaker, Srila ma'am, moderator of the session, Kavita, and the entire postgraduates and the faculty who joined for the program. That's the most important, the participants that ensure the success of the program. No? So with your permission, I adorn the presidential caller on Dr. Sudeep.
May I now request Dr. Sudeep, our very vivacious and dynamic president of IPS Kerala State Branch. May I request Dr. Sudeep to deliver his presidential and welcome address. Dr. Sudeep. Unmute, Sudeep, unmute.
Thank you, Rupesh sir. Thank you, Kavita. And respected speaker, Srila ma'am, and all dignitaries attending this today's webinar. And a warm welcome to Srila ma'am from Indian Prosthodontic Society, and each and everyone attending this webinar. And today's talk is very useful, and it's a comprehensive and accurate radiographic assessment is a crucial aspect of dental implant and treatment planning. So I request everyone attending this webinar to be keen and make use of this knowledgeable talk. And I hand over to Dr. Manju.
Yeah, thank you, Sudeep, for those warm words of welcome. Ladies and gentlemen, any scientific talk like this, the moderator of a program like this has to be something. The program has to be conducted like a poetry. It is.
Platform bottom-up approach. The first is a top-to-down.
Yeah. So, like I said, a moderator of a program like this has to conduct this program like a poetry. ഒരു കവിത പോലെ സുന്ദരമായും മനോഹരമായും സ്ട്രക്ചർഡ് ആയിട്ടും ഈ പ്രോഗ്രാം കണ്ടക്ട് ചെയ്യേണ്ടത് ഈ പ്രോഗ്രാമിന്റെ മോഡറേറ്ററാണ്. സോ ഇറ്റ് ഈസ് നോ സർപ്രൈസ് ദാറ്റ് വി ഹാവ് a moderator herself, Kavita. It is my great pleasure in welcoming Dr. Kavita Janardhanan, the moderator for this program, and I invite Dr. Rajesh C, our treasurer, to introduce Dr. Kavita, our moderator, to this audience. Over to you, Rajesh.
A very good evening to all. Respected President of the Indian Prosthodontic Society, Kerala State Bank, Dr. Sudeep Sharachandran, our Secretary, Dr. Manjuvi, immediate past President, Dr. Cherian KP, President-elect, Dr. Rupesh sir, the Executive Council members, my dear teachers, seniors, colleagues, and dear students. To handle an hour-long session is a difficult task. But a much more difficult task is the coordination of the session from tip to toe. I'm extremely happy and privileged to introduce the modest moderator of the session, Dr. Kavita Janardhanan, Associate Professor, Department of Prosthodontics, Government Dental College, Trivandrum. An exemplary academician and clinician, Dr. Kavita did her graduation from Government Dental College, Kozhikode in the year 2002 and post-graduation from Government Dental College, Trivandrum in the year 2008. In the same year, she joined as a senior lecturer at Sri Mugambika Dental College, Kulashegaram, and she was working there until she joined as assistant professor at Government Dental College, Trivandrum in the year 2013. Becoming a postgraduate teacher in 2019, she has numerous publications to her credit. I am very happy to introduce my own colleague at Kozhikode and Trivandrum, Dr. Kavita, to handle the session carried out by my own teacher, Dr. Srila. So, over to you, Kavita.
Thank you, Rajesh. Kavita, the stage is all yours. Unmute, Kavita, unmute.
Dr. Rajesh, that's kind of you to say. Thank you so much. Dr. Rupesh sir, thank you for the kind words, sir. So let me move on to my official introduction of the speaker. Before that, President, IPS Kerala State Branch, Dr. Sudeep Sharachandran, Dr. Manjuvi, Dr. Rupesh, and other executive members of the IPS Kerala State Branch, senior faculties and colleagues from various specialties, practitioners, and dear PG students, a very good evening to you all. So today we are here to listen and learn about radiographic imaging of dental implants with special reference to CBCT, and which is a cherished topic, not only for the prosthodontist, but for all specialists dealing with CBCT and implants. So this evening, we have with us a befitting faculty to sail us through this subject. So with great pleasure and honor, I present before you Dr. Srila Ellis, Professor and Head, Department of Oral Medicine and Radiology, GDC Kottayam. She is an eminent educator and an eloquent speaker with an in-depth knowledge of the subject at hand. She is an alumni of GDC Trivandrum, so from where she has done her undergraduation and post-graduation in periodontics and in oral medicine and radiology. And she is an ardent research scholar and has obtained her PhD from the University of Kerala in the year 2021. She has had a distinguished career with a total of 25 years of teaching experience at various institutions like GDC Calicut, GDC Trivandrum, and GDC Kottayam. She is also a member of the Board of Studies KUHAS and has around 30 publications in national and international journals. She is also a dynamic member of the Training of Trainers program KUHAS, in which she has exhibited her exquisite teaching skills as well as her potential as an actor, which is enjoyed immensely by the audience, including me. She was my teacher at GDC Calicut, and she is a very cool type of person with a warm smile. And so we are honored to have you, ma'am, here with us this evening to enlighten us on this much sought after topic. So thank you. And over to you, ma'am. And you can now start sharing your screen.
Thank you, Kavita, for all those kind words. And Thank you, Rupesh sir, Dr. Sudeep, Manju, for the warm welcome extended to me. In fact, I feel it, I take it as a proud privilege that you have given me this wonderful opportunity today, be with all of you discussing the topic. I'm trying to share my screen as well. That's why I'm breaking off with my talk. Let me see if this will work first. Okay. Is it visible to all?
Yes, ma'am.
Yes, ma'am. Perfect.
Okay, thank you. Right. So, as it was said in the introduction, this is in fact a very important topic for all implantologists, is the radiographic imaging part. So let me begin with due respects for the great discovery, and this will be in this outline of the contents of my presentation, and the significance of radiology. Of course, nothing, no imaging will replace your history taking or proper clinical examination. So that comes first. After taking the proper history and clinical examination, doing the clinical examination, we need certain imaging for, of course, the pre-implant planning, during the implant placement, and post-implant. So now let's have a look what type of imaging, when, why, and how. Okay. So in implantology, why do you need imaging? It is to assess the quantity and quality of the bone, to provide information on the correct placement of the implant, to understand whether the bone reconstruction or sinus lifting is required. Then if you need a surgical template, and to assess the relationship of the implant to the vital structures, and to assess the success of implant osseointegration. Now, what are the phases in implant imaging? As I said, pre-prosthetic implant imaging, the surgical or the intraoperative implant imaging, and the post-prosthetic implant imaging. Now, pre-prosthetic, that is for evaluation of the patient's edentulous site, the bone mineralization, bone type, the available bone in the edentulous area, if there is any pathologies and things like that. And of course, during the surgery, as I already said, the assessment of the position and angulation of the implant, the osseointegration, the healing around the implant, what is the relation with the natural teeth, how is the loading of the temporary processes, etc., can be judged. And post-prosthetic, you need to know about the maintenance of the implant. So you need assessment of crestal bone loss, peri-implant tissue. You need to have an idea of the bone health and any pathology developing. Now, what are the imaging modalities? The two-dimensional conventional planar imaging, that is intraoral periapical radiographs, occlusal radiographs. Then you have the pan as well as the cephalometric. Of course, cephalometry is not much used in implant, but still. And then there are certain quasi three-dimensional imaging, like cross-sectional panoramic views or the tomographic views, and the true three-dimensional imaging, that is a multi-detector computer tomography and the cone beam computer tomography, the magnetic resonance imaging, etc. Now we'll see one by one, like what each one can contribute, or what will be the role in implant imaging. Why you need a 3D, because of the limitations of 2D. So what information will a 2D imaging provide? It will give you an idea on mesodistal width of the bone at the implant site, as well as the supero-inferior height of the bone. And what will it not give? So it will not provide information on the decrease in the bone density or the thickness of the cortical plates, the true relationship of the natural tooth to the alveolar housing, and the proximity of the implant site to adjacent vital structures. All these are very, very important during implant placement. So now let's have a look at what or a rather a comparison of the contributions by 2D and CBCT imaging. As already said, in 2D imaging, you can have an idea on the mesodistal width of the bone as well as the supero-inferior height of the bone that is available, but the buccolingual width or the accurate linear measurements are not possible with 2D imaging. And decrease in the bone density or the thickness of the cortical plates or the true placement of the natural tooth is also cannot be assessed by 2D imaging. And the proximity to the vital structures are also not accurately assessed. Now, comparing CT and CBCT, though the radiation dose as well as the scan time is very high for CT, it provides the accurate bone density in the Hounsfield units or the HU units. Whatever HU value you get in a CT is very accurate, whereas the disadvantage of CBCT is that it does not give reliable Hounsfield units or an idea on the bone density as such. That is, you cannot depend on the HU unit that you find in a CBCT. And the reconstructed images of CBCT are highly accurate, whereas that of CT is not accurate and not good for your measurements. Now, this is a summary of the 2-dimensional and 3-dimensional characteristics of the imaging modalities. Here you can see that, of course, the 2-dimensional imaging modalities give, or there is only minimum of radiation dose, whereas for the CT and CBCT, the dose is, of course, very high, but the accuracy part is very high, reproducibility is very high, there is absolutely no magnification or distortion. And then, of course, the cost factor and the patient position, that is in CT, you can have the supine position. Now there are CBCT machines also coming up which provide the supine position or the comfortable lying down position for the patient. But as of now, it is very similar to a panoramic machine. The patient is usually is sitting or the standing position while taking the CBCT. Now, summarizing according to our requirements, the advantages and disadvantages, how will you decide whether to go for plain radiography or for the 3D imaging? As you can see here, that is the multiple implants or large edentulous span, and when you require augmentation or you don't have an ideal bone height width as required, it is always better to go for a 3D imaging. Otherwise, you can even stop with your conventional or your screening radiographic imaging. That is what I'm trying to stress is that taking a CT prior to an implant placement is not mandatory, because nowadays what we find is people, once they decide that they're going to do an implant, immediately send the patient for CBCT. Personally, I feel that is not necessary always, because if you, as I said earlier, if you do a proper clinical examination and after your screening radiograph, that is, if it is a single tooth implant, you can very well do it with IOPA, ordinary IOPA X-ray, or with your OPG. You can assess the pedestal as well as the supra-inferior height, and the rest with your clinical assessment. You can very well proceed for a implant placement without CBCT even. So when do you actually need all the planning that is with your CBCT? So for that, let us see what information will the 2D images provide. You have you can find the position and the size of the relevant normal anatomic structures, including the inferior alveolar canal, the mental foramina, the incisive or the nasopalatal foramina canal, the nasal floor. Everything can be seen in 2D images also. The shape and size of the antra and the relation to the adjacent teeth, presence of underlying disease, all this, that is something like osteosclerosis or some pathology like that, all that can be identified from a 2D imaging. And presence of buried teeth or root remnants, then the quality of the alveolar crestal bone, then you can do the measurements as well. Then the amount of cortical bone present, the density of the cancellous bone, the trabecular space, what is the pattern, trabecular pattern of the bone, everything can be assessed by 2D imaging itself. Now, when do you need the CBCT for implant planning? As told earlier, usually when it is multiple implants, or even if it is a single implant and you feel by your clinical examination, evaluation, and your radiographic screening, if you feel that the bone is not of adequate quality or the quantity, then definitely you should go for a proper assessment with the CBCT. And as I told, when you are asking for a CBCT, you should specify your area of interest. That is, when if you are going only for a single implant placement, please see to it that you specify that you want to see this particular area, because in that case you can choose a small FOV, and that helps a lot to the patient, because thereby you help in reducing the radiation dose. So the advantages which should be highlighted about CBCT is the dimensional accuracy and the reproducibility of the linear measurements. Then of course there is no superimposition, then there is less dose, then the field of view, as I said, the FOV can be chosen as small, medium or large depending upon our area of interest. Then it is much less expensive, less time consuming and less radiation than compared to the CT, and it provides more accurate measurements as well. So these are the advantages of CBCT. Now talking about CBCT images, you should have an idea like in what all views can you see, or what are the options that we get with a CBCT image. See, actually I'm not going into the exact principle of acquiring of CBCT images, but still let me tell you what is the basic in a CT and a CBCT. In a CT, you decide upon what all slices or which all levels you want to see earlier. That is decided. And then you set the machine to scan. So what happens is you have a fan-shaped beam which will pass through all the levels that you have selected and will give you the slices or the images at that particular level. And then if you are going for a reconstruction of a 3D imaging, all whatever images, whatever slices has been obtained, that will be put together, and then you get the 3D reconstruction. Whereas the difference is in a CBCT is you have a cone-shaped beam which will move around the head of the patient once, and it will acquire the whole image. So you have the whole loaf of bread, and then you cut it according to your liking. You can slice it and you can view at any point or any slice. And the slices, how do you get it? It can be on the 3-axis. That is what you see in this image. That is, you have the axial cut. This is it. This is the axial cut. Then you have the coronal, which is of course parallel to the coronal suture. So this is the coronal, and then the sagittal. That is parallel to the sagittal suture. Okay, so you get to view the CBCT images in all these three planes, and of course you have the 3D reconstructed image. So that is about multi-planar reformatting. That is, you can have cross-sectional views of your choice. You can decide like where you want to see. You can see all those cross-sectional views, especially with the implant program. We'll go into the details. Now, this is why you need a pre-implant assessment. That is to understand the topography of the alveolar bone, the quality and the quantity of the bone, proximity to vital structure, and virtual implant placement. I'm sorry, you'll find me repeating the same thing several times. Actually, I know it is a repetition, but what I intend to do by repeating is just stressing, because I understand many of the postgraduate students are here. But for the eminent implantologists, please forgive me. I know this might turn to be quite boring to you, but still, anyway, let me do it. Now, ultimate success of a dental implant is by radiographic assessment, proper treatment planning, and proper post-treatment assessment. So that is the implant window, which will give you these views. Now, how do you acquire all these views, or how do you get to see all these views in a CBCT image? All that we'll see. These are the various cross sections whereby you can take the measurements very easily. All this you get in the implant window of the CBCT images. How to get a panoramic view from a CBCT image? What do you do? How do you draw a panoramic contour? I have a small video on that. Let me see. So this video will show you how to draw a panoramic curve, or how you can get a panoramic image from a CBCT volume. What you see here is a tool to draw the panoramic curve. So you go along the middle of the teeth, along the arch, and you can see the image of the pan image coming up. See. So here we have the pan image ready for you.
Excuse me, ma'am.
Yes.
The video is not visible, ma'am.
Oh, sorry. But I can see it on my screen.
It's
Okay,
not,
let me see.
here, ma'am.
So what do you see now?
Just that writing, draw panoramic contour such that the panoramic line passes through center of the ridge. That's all.
Oh,
It's not playing.
Madam, go to presentation mode.
Yes, I have gone to that, and that is what I'm doing actually. And on my screen, the video is playing also.
Like,
Madam, present F5 press ചെയ്യും madam, F5. അപ്പോൾ presentation മോഡിൽ പോകും.
അല്ല, അത് വന്നു presentation മോഡിലേക്ക് പോയിട്ടാണ് ഞാൻ വീഡിയോ പ്ലേ ചെയ്തത്.
അല്ല, ഇവിടെ presentation മോഡ് അല്ല മാഡം കാണുന്നത്, സ്ലൈഡ് ഷോട്ട് റിവ്യൂ ആണ് കാണുന്നത്.
അയ്യോ.
മാഡം ഒരു പ്രീവിയസ് സ്ലൈഡിൽ പോയിട്ട് മാഡം ഒന്ന് presentation ഇതിൽ പോകാം. എക്സിറ്റ് ചെയ്തിട്ട് ഒന്നുകൂടെ presentationലോട്ട് പോകാം.
ഓക്കെ, നോക്കട്ടെ.
or if the video is on the desktop in the play ചെയ്യാൻ എനിക്ക് തോന്നുന്നു.
ഡെസ്ക്ടോപ്പിലുണ്ട്.
അങ്ങനെ ആയാലും മതി മാഡം. I would like to make a small announcement in between. Participants, please post your queries in the chat box in YouTube as well as in Zoom platform.
Is it visible now?
No, ma'am.
മാഡം നമുക്ക് പ്രസന്റേഷൻ സ്റ്റോപ്പ് ചെയ്തിട്ട് ഡെസ്ക്ടോപ്പിൽ നിന്ന് വീഡിയോ മാത്രം പ്ലേ ചെയ്യാൻ പറ്റുമെന്ന് നോക്കാം.
അല്ല, അത് ഞാൻ നോക്കി എന്നിട്ട് വരണില്ല.
മാഡം ഇതൊന്ന് മിനിമൈസ് ചെയ്യാൻ പറ്റുമോ ഈ സാധനം, ഈ PPT?
ഇപ്പൊ മിനിമൈസ്ഡ് ആയോ?
ഇല്ല
ഇല്ല, അല്ല ഇപ്പൊ ആവുമായിരിക്കും, ഒരു ഡിലേ ഉണ്ടാവും. നോക്കട്ടെ മാഡം. ഇല്ല, മിനിമൈസ്ഡ് ആയില്ല. മാഡം ക്ലോസ് ചെയ്യാമോ PPT?
ഓക്കെ,
നമുക്ക് എന്നിട്ട് ഓപ്പൺ ചെയ്യാം, വീഡിയോ പ്ലേ ചെയ്തു.
ക്ലോസ് ചെയ്ത് ആദ്യം തുറക്കണോ?
ക്ലോസ് ചെയ്തിട്ട് ഡെസ്ക്ടോപ്പിലെ വീഡിയോ പ്ലേ ചെയ്യാം മാഡം. നമുക്ക് ക്ലോസ് ആവുന്നില്ല ആക്ച്വലി.
എനിക്ക് പക്ഷേ ക്ലോസ്ഡ് ആയി.
മാഡം ഷെയർ സ്ക്രീൻ ഒന്ന് സ്റ്റോപ്പ് ചെയ്തിട്ട് മാഡം ഒന്നുകൂടെ ഷെയർ ചെയ്തിട്ട് വീഡിയോ പ്ലേ ചെയ്തിട്ട് PPT-ലോട്ട് വരും മാഡം. അപ്പം സോൾവ് ആവും.
ഇപ്പം ഷെയർ സ്ക്രീൻ മാറിയോ?
മാറി. ഇനി മാഡം ഷെയർ സ്ക്രീൻ ചെയ്തിട്ട് ഡെസ്ക്ടോപ്പിലെ വീഡിയോ പ്ലേ ചെയ്തിട്ട് നമുക്ക് മറ്റേ PPT-ലോട്ട് വരാം.
While we are sorting out this technical issue, any queries connected to this particular topic, all the PGs and delegates, please post it on the chat box. Any queries connected to this? Anything you want to ask Madam later, which Kavita will take up later. So you can utilize this time to post your questions. Please type it on the inbox.
Now my screen is visible.
സ്ക്രീൻ മാഡം സ്ക്രീൻ കാണാം, പഴയ പോലെ തന്നെ ഉണ്ട് മാഡം. വീഡിയോ ഇപ്പോഴും ആയിട്ടില്ല.
ഇപ്പോഴാവുന്നുണ്ടോ?
ഇല്ല മാഡം.
ഇല്ല.
നോ മാം. പ്രശാന്ത് സർ പറഞ്ഞ പോലെ മാഡം ഡെസ്ക്ടോപ്പിൽ നിന്ന് ഒന്ന് പ്ലേ ചെയ്താല് ഷെയർ സ്ക്രീൻ ചെയ്തിട്ട് എന്നിട്ട് പ്രസന്റേഷൻ തുറന്നാൽ
ഓക്കെ, നൗ പ്രസന്റേഷൻ നേരത്തെ കാണുന്നുണ്ടോ?
പ്രസന്റേഷന്റെ സ്ക്രീൻ കാണുന്നുണ്ട് മാഡം.
Let me see if this will work.
Presentation mode അല്ല മാഡം.
അല്ല, മറ്റേ മോഡിലാണ്. ഇപ്പോഴോ?
ഇപ്പോഴും ആ മോഡിൽ തന്നെയാണ്.
When I start the video, it comes like your screen sharing is paused. So I don't know what to do. I'm sorry.
മാഡം നമുക്ക് ലാസ്റ്റ് പറ്റുമെങ്കിൽ നമുക്ക്
പറ്റുമെങ്കിൽ നോക്കാം.
Video, I think we'll continue with it.
Yes. So I'm sorry. I don't know why that happened, because on my screen it is working perfectly, and why it is not coming over, I don't know. Let's just trying again. It's not visible even now.
No,
Is
ma'am.
it?
No, now the presentation is not visible.
Presentation is also not visible.
No, ma'am. There is no screen sharing right now.
Oh. And now,
Yes, ma'am. Is this a video playing?
yes, that's it.
Correct.
I think we'll start from the beginning.
Yes,
Yes.
ma'am. Yes.
It's a very short video. You can see the pan image which comes up as you draw the panoramic curve. Do you want me to do it again?
Yes, ma'am. We will see from the beginning.
Okay, right. So this is how you draw a panoramic contour. That is, you have a tool. You can see with the, that's it, with something like a pencil. You put the dots at through the center of the teeth, and you can see the pan image coming up below. So this is how you get a pan image from a CBCT. Okay. Now I have one more small video. I think I'll do that as well, and then go with the presentation. And that is on nerve tracing. It's my presentation. This is actually how you trace inferior alveolar nerve. You can see that. Can you see now?
Yes, ma'am.
Right. We'll have a look at all the videos and then go back to the presentation. I think that will be better. So all these options are available in the software. There's nothing like you don't have to take the credit because it is being done by the software only. Only thing is you should know what tool to take and how to do it. So you can see the cross-sectional images in the as you get in the implant view. Now the nerve has been traced perfectly. You can see in the 3D reconstruction the exact course of the nerve. Okay. Do you want to see it again?
I don't think so, ma'am.
Clear. It's clear.
Clear, ma'am.
Okay, fine. So now let me go back to the Can you see the screen now?
No, ma'am.
No?
No.
Oh.
Yeah, it's visible now, ma'am.
So nerve tracing. You have seen now the mesiodistal width assessment of the edentulous span. I'm sure those of you who are routinely or regularly doing implant cases must be very familiar with this kind of measurements, how you take it. You have the scale tool in the software itself, and you can take the measurements very easily. You just have to put the 2 points and automatically you get the values there. Now, how to choose the cross section? That is, where exactly will you take, which cross section do we have to take? So that is decided by taking the buccolingual, mesiodistal width, and then you find the midpoint. So the midpoint of the edentulous span, that is taken as the optimal site for implant placement. The minimum distance from the outer surface of the implant to the adjacent tooth, all that you know very well. It should be at least 1.5 millimeters. And then the distance between two implants, it should be minimum of 3 millimeters. That is 1.5, 1.5 from either side. Okay. Now the supero-inferior height, that is depending upon the position of the vital structures. See here in the image that is shown, you can see the inferior alveolar canal. So it should be 2 millimeters away from the canal. And this is how you measure the supero-inferior height. And in the same cross section, you can do the buccolingual width also, you can measure. So this is something which all of you should keep in mind. That is the minimum distance from the adjacent structures: implant to tooth, implant to vital structure, implant to implant, and implant to the labial or lingual bone. Now, each of the vital structures. See, I'll just go through the images because I think already we have lost quite a lot of time. And all these must be very familiar to you implantologists. So this is how we do. That is, you identify the vital structure, keep at least 2 millimeters away, and then you select the points to get the measurements. Another anatomic landmark, that is a lingual foramen. So depending upon the site, if it is in the mandible, then you have the mental foramen, the inferior alveolar canal, then now about the buccolingual width measurement. Ideally, we should take at the maximum width as well as the minimum, that is maximum convexity and maximum concavity should be taken into account, and you should take the width, because all this will determine the size of the implant that you are going to place. Here again, I had a video on the virtual implant library, but I think we'll lose a lot of time choosing the videos. So shall I skip the video?
Okay, ma'am.
Okay,
If we have
fine.
time at the end, we'll play the video then, ma'am.
Okay, if we have time, we'll come back and then play. Right. So actually, this is this window shows you how it looks like the virtual implant library that is available along with the CBCT software. This is from the PlanMaker machine, that is the Romexis software. Depending upon which machine that you have, there'll be slight differences, but basically almost all softwares are the same. So it is something, you will have something very similar like this. And here you can see the implant library, you have the abutment library, the crown library, and you can even do a search in the library. That is, you can see if the implant of your choice is available, or something similar to what you're going to put. At least that you will definitely get, because they have, I think they have a n number of different implants and abutments and the crown, everything has been listed there. You can choose even the color and things like to your liking, you can change, and you can choose a virtual implant, you can place it at the implant site, you can adjust the angulation, everything gets set, and you can even plan for a guide for your surgery. So you can actually visualize the implant in position prior to surgery itself and make the complete assessment, that is the exact size and type and whatnot about the implant. Here, anyway, this video is working, thank God. So here you can see like how you can go through the cross sections. You can view all the cross sections, and you go to the implant library, choose your implant. You can change the color. You can position it, angulate it. You want to change, once you put it in position and you feel, okay, this is not right, I want to change, you can go replace it, get a different one and place it again. Whatever you want to do, you can do. You can even visualize it on the 3D image. You can see it within the bone. And then you can assess the quality of the bone around the implant using the implant verification tool. That is also provided with the along with software. But here I would like to tell you, all these options are available only in the actual system along with the machine. That is, wherever the scan has been taken, only from there you can do all this. What you get in a CD will not provide you an implant library. All this is not possible. At Lisha, you cannot sit at your office and do it. You will have to go and sit along with the imageologist, or at least go to the place where the scan has been taken, and only from there you will get all these options. Right. So that was about virtual implant placement. I hope that part is clear. And then we have the crown library. You can choose from the like your choice of crown, and even visualize that too prior to your implant placement. Okay, now going on to the bone density assessment. All that I'm sure all of you are very familiar. And talking about the different types of classifications for the bone types and all. As you know, this is one of the most common one. Anyway, you should know about all these 4 types. Type 1, 2, 3, 4. Of the 4, if you ask which is the best, of course it is type 2, where you have enough of cortical bone as well as quite an amount of cancellous bone, which will provide the vascularity. Whereas type 3, 4 and all, you have very soft bone. The cortical plate is minimal. So when you are assessing the bone, make sure what type of bone it is, because that will help you in planning your surgery. The method required to place the implant. You know, when it is very soft, you cannot do a fast drilling and things like that. You have to keep in mind. Of course, the mixed classification is actually based on the HU units. So it's actually, this classification was put forward depending on the CT images, where you get accurate HU units. But these days, even the HU unit that is provided by the CBCT, you do a mixed classification and you assess bone as D1 to D4. Actually, that is not right. It is based on the CT image only. But still this is working anyway. It is working fine, I should say, though the HU units provided by the CBCT is not accurate. I'm not spending more time on this. So this is about the HU unit and the bone. I will summarize the bone assessment. I've got some. This is it. That is the evaluation of the alveolar bone status can be summarized in this way. That is the bone quantity, the bone quality, all that you have to have an idea on based on the Lacombe and Saab classification about the alveolar ridge as well as the quality of the bone, and the Mish classification from D1 to D5 depending upon the HU unit. So where you get each type of bone. D4 is usually the posterior maxilla where you have more of spongy bone and very thin cortical plates, and D1 is the anterior mandible where you get thick cortical plates and minimum amount of the cancellous. So choosing your implant size is always by the bone height and the bone width, what is available. When too little of bone is available, you go for bone augmentation, you go for sinus lift, etc., etc. And when that is not possible, other options left are the zygomatic implants and the pterygoid maxillary implants. So I'm not going into the details again. Another thing, all this implant planning, if it should work fine, this is something which I would recommend. That is guided surgery for implant therapy. These days, 3D printing is becoming so common. You can definitely print your surgical guide, which will help you in the exact placement of the implant as you have planned. That is, for your planning to work out, I recommend that you go for a proper stent, especially when it is multiple implants. This is very useful, very helpful, and so you will get things done exactly as you have planned. That is what I would always ask. That is, your pre-implant workup you should do properly. That is, when you are asking for a imaging, that is CBCT image, please do a proper wax up. You do a radiographic stent preparation. Radiographic, what I mean is a radiopic material should be placed, and then you send the patient for the imaging, so that we imagologists will be having an idea like where you're going to place the implant, what exactly you want to see. Or when you write the prescription for the radiograph, when you're writing your requisition for an imaging, please be specific. You write like what exactly you want to see, where exactly are you planning to give the image, what exactly what info you want from the images. If you can write it in detail, more good, you will get a better report as well. That is what I feel. So that is about the 3D printed surgical stents, the guides for implant placement. Now coming to the post-implant imaging assessment. So post-implant imaging, actually CBCT imaging is not recommended. You can always go for 2D imaging itself. That is, you need to go only if there are any signs of any complication. That is, you feel that your implant is not stable, there is implant mobility, or you find there are some problems, or you feel that the patient is having say the patient reports with sensitivity or numbness or pain or some sort of other symptoms, then definitely you'll have to go for a proper evaluation, and then definitely CBCT is mandatory. Otherwise, you can always do the post-implant evaluations with your ordinary plain radiographs. Now, these are some of the complications following or the failures following implant placement. This is that of a perforation. Then the proximity to the adjacent structures, you can see this is retrograde peri-implantitis following the implant placement. There's been no osseointegration here. It is too close to an adjacent tooth, and that tooth has lost its lamina dura. Then there can be fracture of the implant, which could be due to uneven distribution of load. So all these assessments, you will need a CBCT. So the radiographic appearance and the clinical implication. That is, you get a thin radiolucent area closely following the entire outline means poor osseointegration. Then the crestal bone around the coronal portion is lost. I think a minimal, that is during the first year, you can have about 1 millimeter loss and 0.1 millimeter during the following years. All that is can be accepted as normal. But if it is more, then definitely your implant is having problems. That is what you should take into account. And this is fracture of the implant fixture. It is due to unfavorable stress distribution during function. And what are the limitations of CBCT? Of course, it has got a low contrast range. Then artifacts, especially post-implant, when you are taking the images, you will get a lot of artifacts, and hence the exact evaluation of the peri-implant area is quite difficult. That is definitely an limitation. And then, as I've already told several times, that is about the Hounsfield units. And CBCT, let me conclude saying that it is only a complementary modality. And also, let me say that all implantologists, please have us imagiologists as your friend. Let us go hand in hand, which will help you more in your implant placement and which will help us in giving you a proper report as well. With that, let me end my presentation. Thank you. I hope I have not taken too much of my time, your time.
No, ma'am. Thank you, ma'am. So that was a crisp presentation with a crystal clear insight into the topic. And although there were some initial glitches while playing the video, but finally it came out well. And the videos were really informative. And it was really interesting to watch those videos with that as virtual placement of implants. And I think the postgraduates really liked it. And if there are any queries, please post it in the chat box. We'll discuss. Now the forum is open for discussion.
Thank you, ma'am, for the informative session. Ma'am, actually, I have a small doubt. So we were telling now about the Hounsfield unit. It's not reliable in this, but it's written there, no? Usually we rely on that one. So how about that, ma'am?
That's what I said. I know all of you, I mean, because it comes as units, and even radiologists, we know that it is not right. But still, we also do have a look at the Hounsfield unit. The thing is, in CBCT, as I've told you, there's a difference in the way the image is acquired. So it does not give an actual value of the bone density. And you cannot rely. That is, if you want, you can try. That is, when you do it at different times, you will get different values. That is a disadvantage of CBCT as of now. And of course, research is going on to improve that aspect. And maybe in the near future, we will have CBCT machines giving you accurate Hounsfield units like the CT machine itself.
Okay, you mean, ma'am, in different slides, it is different values they are giving. Is it so? Or,
actually, you have the whole volume in the CBCT.
okay.
And you stop, you scroll through the whole volume. whichever slice you are taking, let it be coronal, sagittal, or axial, whatever it is. So at any point of time when you stop, see that you get to see at that level, isn't it? And then when you put the pointer there, you get a value about the Hounsfield unit. That is in the grayscale. But that is not reliable in the sense that when you scroll it again, and maybe at the same point you stop again, but at that time you'll get a different Hounsfield value. That is because whatever is there in the software is the whole volume, and it does not give a clear-cut view of whatever slice you are taking.
Okay.
That is a problem.
It's a full volume that overall this thing there.
Yes, yes, that is it.
Okay, ma'am. Thank you. Thank you. Any other queries? Postgraduates?
Ma'am, there is one question in the chat box to how to identify the bone quality like D1 and D2 from CBCT.
That is exactly what we have been trying to say. You are not supposed to do it exactly from the CBCT. You have other softwares for your information. BG, since you have asked, I'm telling you, we have different softwares which will give you the exact bone density from CBCT images also. So you'll have to take this CBCT image and put it into those particular softwares and then do it. Actually, very recent literature, that is in 2023, this year itself, a new classification has come up by Wang et al. But that has not been universally accepted. In that, they're bringing out this way. That is with using a different software where you get the exact bone density and then they are classifying the bone. But everything is similar. So, and till date, like people have been, as Manju madam has said, people have been depending on these Hounsfield units and it has been working perfectly to our luck.
I hope the doubt is cleared. One more doubt by the same person. Is there any relevance in slice thickness of CT associated with the accuracy of a patient-specific implant fabrication by 3D printing? That if there is any relevance, that should be the thickness. What should be the thickness?
Actually, if you are going for 3D printing from a CT image, you should take ideally 1 millimeter slices. Only then you will get accurate. But for 3D printing, our CBCT images are excellent. So you can very well go for 3D printing from CBCT image. What we get is a DICOM image that will be converted to an STL format. That is a stereolithographic format. And from there, you can go for the 3D printing. That will be done by you just send the DICOM image to the lab where you are going to get it printed out. They'll do the STL formatting and the printing aspect. So we don't have to bother about it. So actually for 3D printing, I would recommend CBCT only and not CT.
Okay.
One query in between.
Yes, ma'am.
So actually, how about the slice thickness here, ma'am? The other one, I think we can change according to our necessity, no? The 1 millimeter or 0.6 millimeter that overlap. But how about the slice thickness here, ma'am, in CBCT?
In CBCT, you don't have to worry about the slice thickness at all because you have the whole thing with you. The whole volume is there.
Okay. So in that way, directly it is going for this.
You can take any slice you want to see, you can see.
Okay, okay. Yeah.
That's it.
Thank you.
Ma'am, Dr. Prashant is asking a question. Is there any other radiographic techniques in case of borderline cases?
What do you mean by borderline case? I didn't get it.
Dr. Prashant, can you please explain?
Madam, in cases where when we decide whether we need to go for sinus lift, or in cases whether in such cases, that is what I mean by borderline cases.
Okay, that is, you mean to say you don't have adequate bone?
Yes, yes. We are very doubtful about the implant.
Definitely, you have to go for CBCT in such cases. That is out of question because CBCT has to be taken there. I said in the at the beginning, I said you don't have to go for a CBCT always. That is only when you can do a clinical assessment and with the screening radiograph, be it the panoramic image or the IOPA, you can make out the buccolingual and the supra-inferior height and with your clinical evaluation, you find that there is adequate bone, everything is fine. In that case, you don't have to go for a CBCT. That's what I said. Otherwise, in such all other cases, when you are in doubt, you should go for a CBCT. You should take the exact measurements and find out, and then plan accordingly.
So you mean to say that CBCT is the gold standard in your implant imagology? If not, where you feel that we needs improvement?
I wouldn't call it as a gold standard because we have already said the limitation. See, the HU unit is a great limitation, and there are other limitations as well. So I wouldn't like to call it as a gold standard. In fact, there is nothing like gold standard in imaging for implant placement as of now. Whatever options we are, we'll try to take the better one. So CBCT is a better option. That is all I can say.
Madam, practically what I have seen is that some of the clinical situations, the assessment that we get from CBCT, when we clinically approach the case, I mean, sometimes they differ. The inference we got from CBCT and actually what we see in clinical cases when we do the.
You have to put a margin of 1 millimeter.
Yeah, that's
even though it is said as to be very accurate and everything. As you said, from our practical experience also, we have found that we have to put a margin of 1 millimeter. That will keep you safe.
That was my question. What in borderline cases? I mean, that is 1 millimeter clearance. We should always keep it in mind, right, ma'am?
That you have to keep in mind always. That will be better because we have had many instances where we said this is accurate and all that, but finally we found that it was not so accurate. So after that, we always recommend the 1 millimeter margin.
Thank you, ma'am. It was a very nice session, very informative. And Kavita, you have done a fantastic job, all the organizers. Thank you, ma'am. Thank you.
Thank you. Thank you very much.
Ma'am, one more question, ma'am. The patient usually asks whether placement of implant affects later MRI imaging. Is there any problem with that? There's a very frequent question from the patient. That's why.
Yes, actually, implants don't affect the MRI imaging. It is either way. That is whether the implant will affect the image and whether taking an MRI will affect your implant. You should think in either way. The implant affecting the images, as you said, there can be a slight artifacts coming up, but that is only if you're taking an MRI in the region where the implant is placed. Otherwise, there's no question of artifact or anything.
Okay.
And nowadays, all these implant materials, I think zirconia, etc., all that, that is not magnetic, and so it is not affected in the magnetic field. Only the ferromagnetic materials that is being used as implant, only when that is used, you have to be apprehensive. But that too, there is no report in the literature anywhere of any implant getting pulled off by the patient entering into the magnetic field.
Okay, thank you so much, ma'am. Thank you. Any further questions? Okay. So, ma'am, we request you to accept a token of appreciation. I request Dr. Rupesh sir to hand over the certificate to Srila, ma'am. Rupesh sir.
Yes, Srila ma'am.
Thank you so much.
And it really was accelerating and in-depth, crisp and clear, like how Kavita just said. And the pace at which you went also, I think, people who listen to what you spoke, I'm sure they also understood, because the pace was very leisurely. You have a very homely look about yourself, Srila ma'am. And two of my very favorite characters are, one is Superman. I like Superman very much. So obviously, when you like Superman, you need to like super women also. Superwoman. And Superman and Superman, one of the...
I'm flattered. Thank you.
Wait, I'm coming to what I'm trying to sell the point. Very peculiar, a lot of superpowers these people have. But one of the superpowers which has intrigued me as a child is X-ray vision. Okay, Superman and Superwoman, both of them have X-ray vision. Women in general have an X-ray vision, especially married women, their vision get more intensified, and their vision is like an
They
excellent.
have to.
So here we have a superwoman in Srila ma'am, who's a specialist in oral medicine and radiology and speaking to us. So, you have been fantastic. You have been super. And the last slide also, what you posted, Srila ma'am, I liked it very much. You are a friend. There is no dentistry without, imaging. It's a fact. Be it any specialty. Imaging is the basis. You need to see. You can assume clinical knowledge, experience, and things like that. But ultimately, when you need to be confident as a clinician, obviously, we need to rely on the people like superwomen like you. So, thank you for being with us today. And we are also, as a society which is open to interdisciplinary talk. So, you are probably one of the few earlier people who we have invited from the other specialty to speak to us. So really honored to have you, Srila ma'am, and kindly do accept this certificate. I'm sure we'll try and send you a print copy, hard copy to you, to your
Thank
office.
you.
So Rajesh is a treasurer, so you can spend some extra money from his pocket and print certificate for you. Thank you very much,
Thank
ma'am.
you so much. It has been, I really enjoyed being with all of you, because as you said, most of you are really very dear to me, Rajesh, then Kavita, my students. So, and of course, my special thanks to Dr. Prashant. Actually, he has been telling me for so many, I think it's been a few months, he started telling me, ma'am, please. And anyway, thank you all for having given me this wonderful opportunity. Thank you so much.
Thank you.
Right.
Let me once again, I need to thank Dr. Prashant, because like you said, he was the one who was instrumental in getting you here with us today. So thank you, Prashant, and thank you, Kavita, for this wonderful comparing. And thank you to all the people who are listening to us. Over to you, Kavita. Manju, if you can, now for our model.
I request you to hand over the certificate to Kavita, who has moderated the session very well. Thank you, Kavita. I request her to hand over the certificate to Kavita.
കവിത പറഞ്ഞ പോലെ വളരെ കാവ്യാത്മകമായി പേര് അതിനെ അറിഞ്ഞിട്ടാന്ന് തോന്നുന്നു കവിതയ്ക്ക്. സോ കവിത, താങ്ക് യു for moderating this session very, very well, and our deepest of appreciation to you, Kavita. Can you accept this certificate of appreciation? Thank you.
So, shall I leave?
Sir, now the last part, the vote of thanks, no?
Yeah, I now invite Dr. Manju for the vote of thanks.
I think before moving to vote of thanks, I think I would like to mention some of the IPS Kerala activities. Ma'am, only 2 minutes, just for the participants. Otherwise, they may leave. That's why.
Okay.
Actually, our executive committee, we have planned monthly at least one scientific session, either workshop or some training programs or some scientific activities. Our executive committee has decided like that. So please be a part of it. Actually, we have started this term, our executive committee, this term we have started with the rebase program we have conducted. After that, we are happy that this month, we could conduct 2 programs. One maxillofacial prosthodontic workshop we have conducted, and the next is ma'am's very informative session. So 2 sessions we could conduct this month. So the future months also, we are planning many informative sessions. So all the postgraduates and faculty, kindly be a part of this. You try to make use of all this. Okay, that's our request. This is from the IPS Kerala, the entire executive committee member I am talking. Okay, now moving to my duty, the vote of thanks. So first of all, ma'am, we are immensely grateful to you for your excellent presentation, for your sharing your expertise about the radiographic imaging, all those things. As Rubesh sir rightly said, in a very simple way, you were explaining the inside, deep inside, you were explaining in a very simple way. Thank you, ma'am, for accepting our invitation and sharing your insight. Okay, then the moderator of the session, Kavita, she is very passionate in learning the advanced aspects. Actually, we have attended many maxillofacial prosthodontic workshops together. So his dedication is really commendable and inspiring. Thank you, Kavita, for moderating this session.
Thank you, ma'am.
As I said in the beginning, actually the participants, you are the crucial factor in ensuring the success of the program. So all the participants, thank you for your involvement. And I know you have gained a lot of knowledge regarding the CBCT, the various aspects. See, ma'am was telling, no, it is not the gold standard, but we always feel like that whenever we get to implant case, immediately we ask the patient to take a CBCT. So now I think it's an eye opener. So we can think about that, whether it is required or not, or clinically, if we feel the adequate bone quantity, then I think we can with a OPG or an IOPA itself, that itself is enough. That's new information as CBCT. It's not the gold standard. Okay, ma'am. Thank you for your informative session. Then about the participants, again, once again, thank you all for your active participation. Then about our EC committee, the president, Rupesh sir, always sir's help is there for coordinating the entire session. Then the Rupesh sir, I don't have to tell, no, from minute aspects, sir's touch is there always. So immediate helping hand. Thank you, sir. Then all the executive committee members, then Sri Kumar sir, all of them, they have given their comments and the timely help they have given. Then, as we said in the beginning, Dr. Prashant has taken the initiative for this program. So thank you, Prashant. Then thank you, Dr. Rajesh, and the entire executive committee team. Thank you, one and all. Thank you for attending the session. JIPS.
Thank you, IPS, for giving me the opportunity. Thank you. Thank you so much.
എല്ലാവർക്കും ഓണം
Good night.
മാഡം.
Thank you. എല്ലാവർക്കും happy Onam. Good night.
Good night, ma'am.
Take care.